Ladies and gentlemen, Dr. Maja Segedi.
It is amazing to be here. I've spoken at many conferences, but never in front of this big of a creative audience, and I'm just so thankful to be here and to have listened to all the speakers so far and all the thoughts and energy and creativity. So I will talk to you today about the advances, technological advances in surgery, specifically the robotic surgery. And I'm also interested in how all of these advancements will affect the way we take care of our patients and the quality of the surgery that we provide for our patients. I will also pose a question of whether we are ready for the technology that is the advances that are taking place, and whether there are any things that we need to think about ahead of time to prevent any disasters or damaging consequences for our patients. So, how many people know what this is? Okay, so most of you do. So Hal is a fictional character. It's a ship. It's a computer ship. It's a ship computer on the Space Odyssey 2001 ship, and he had a dual purpose. His purpose number one was to find an artifact close to Jupiter, but he also had a goal of not letting the ship crew know about the mission of the ship, and he had to make a tough decision to try and kill the ship's crew so they wouldn't find out about where they were going. And robotics and surgery is not at this level. Our robots are not autonomous like Hal was. Hal was a computer as well. But maybe in 5, 10, 20, 50 years, we will have to face these decisions and think about this. First, I will talk to you about the history of surgical innovation. I will bring it to what is happening today. I will talk a little bit about the future, and then I will talk about the ethical issues and pose some questions. I first of all want to say that the definition or the meaning of the word surgery is comes from a Greek word, which means work with hands. I'm not going to try to pronounce it in Greek. It's going to sound too funny. Me as a surgeon, the reason why I went into surgery is to heal people with my hands. And now my hands are not always my hands, and they're sometimes the extension, or sometimes I do surgery with the extension of my hands, surgical tools. This is one of the early surgical techniques that was developed 5,000 to 10,000 years ago and perfected over 5,000 years. And this is called trepanation. It was a technique of taking out a piece of a person's skull using a variety of instruments. We know that the patients actually survived and their skulls were able to heal. And this technique was very interestingly lasted for a long, long time. This is a trepanated skull. I should say that some of the images that I will show, if you see them, if you're able to see them, may be a bit disturbing and a bit graphic. They're going to be surgical images and videos, so just beware. We have, in surgery or in medicine, we have a lower threshold for some things, and we take them for granted, so I want to make sure that you guys are aware of anything that comes your way. This is Frère Jacques. He was a surgeon and a barber. Barbers used to perform surgery many years ago. This is in the 1500s, and he is performing cutting for stone. He is removing a man's bladder stone. The man is not anesthetized. He's held down by a lot of other people, and the art, or the most skilled surgeons or barbers at the time were able to perform this surgery within 2 minutes through a cut that goes in a spot that I don't have to describe to you right now. Opens up a person's bladder and removes a stone with a small spoon. There was no anesthetic here, so this was very, very painful for people. This is an example of early anesthesia. Anesthesia means lack of sensation or lack of feeling. And these are some early examples of a patient being anesthetized by ether. This was demonstrated in the 1800s in Massachusetts, in the Massachusetts General Hospital. And it really revolutionized surgery, along with another advancement that happened thanks to Joseph Lister, a surgeon from the UK, who found out and noticed that women who were given birth would get severe infections unless the instruments and the hands of the surgeons were washed ahead of time with a chemical. So the Mayo brothers, who are now who started the Mayo Clinic in Minnesota, went to visit Joseph Lister and became very big advocates of this aseptic technique, which we use every day, probably even outside of the OR these days, cleaning our hands. So new frontiers in surgery became possible. Now patients could fall asleep. They wouldn't have to be, they wouldn't feel pain. We could make big incisions on them, and big incisions were made, and big tumors started being taken out of patients. We were able to treat trauma and big bleeds in the abdomen. We were able to perform open heart surgery. We were able to perform open heart surgery and heart transplantation, liver transplantation, and even put patients on bypass while they were waiting for an organ. So on a machine that was breathing for them or exchanging oxygen and carbon dioxide. Things were just marvelous. So the next big advancement in surgery started as a result of wanting to do all this in a much less painful way. So it was no longer how big of a tumor can we remove, but how can we do it in a way that the patient does not have to be in hospital for another 2 weeks, they don't have to maybe develop a hernia from a big incision, they can go back to work sooner. And this resulted in either minimally invasive surgery. And minimally invasive surgery is performed with laparoscopic instruments. One of them is a camera, and the other ports are instruments that are either knives or suture holders or electrocautery instruments. The abdomen is insufflated with carbon dioxide, which is a very benign gas, and patients can go home in a much shorter period of time. It did initially take a long time for the surgeons to start performing the surgery because the learning curve is so high, but right now there's a variety of surgeries that we perform, and the standard of care is to do it laparoscopically. So most gallbladder surgeries, appendix surgeries, bowel resections are done this way. This is the standard of care. And this is a video, I hope you can see it. This is a camera going in through a port into an animal's abdomen. This is an experimental animal. You guys, you can't see anything, really. I'm sorry about that. You can, basically what this video shows is that a surgeon is picking up a piece of bowel that was injured, and the instruments are straight, so there's no wrist. So there's only rotation right and left. And even though the surgeon is relatively skilled at what he's doing, or he or she is doing, you can see that it takes them a long time to pick up the needle and to try and suture up the piece of bowel. It's very frustrating almost. And a lot of laparoscopic surgery with these straight instruments takes a long period of time to do, to learn and then to do really well. Anyway, towards the end of the video, you should see the way these laparoscopic instruments are levered on the port in the patient, and the surgeon's wrists are actually outside. So the main movement that you need to perform in order to be very, very precise does not happen where it needs to happen. So Intuitive Surgical is a company that came up with a robot that most of us have probably heard of. How many people have heard of the Da Vinci robot, surgical robot? Okay, so fewer than I thought. And they use this pulley principle to design an instrument that mimics a human wrist on the inside of the abdomen. And Da Vinci created this robot in 1495. He called it the mechanical knight. He used a system of pulleys to create this device that was able to sit down, stand up, lift its arm, and even move its head. And these are his sketches, and the pulley that is shown in the sketch here is actually very similar to the pulley systems used in the Da Vinci robot's hand. So the Da Vinci robot's instrument, it mimics all the 7 movements of a hand, and it's also very precise and very small, so it can pick up a grain of rice. The surgeon, him or herself, sits at a console and is very comfortably moving the wrist and performing all the movements, and the robot is doing it in a much smaller space and with much more precision, so there's no tremor. We all have tremor, but the robot doesn't. I hope you can see this. So this really illustrates how precise the robot is, and it's showing the robot peeling a grape. There's absolutely no tremor. The depth of the cut is very, very shallow, and the surgeon is very comfortably sitting, moving his arms in a very, very comfortable, almost effortless way. This is an actual prostatectomy, and the reason I wanted to show this was because prostatectomy is the procedure that was really made for the robot, or the robot was made for it. And not every surgery is benefits from the robot. And the reason for it is because prostate is in a very small, confined space of a male pelvis, which is narrow, and it is fixed in space, so it doesn't require the surgeon to reposition ports into the abdominal cavity. So it can be, you can see the set of movements that the hand can perform. You can see suturing here, actually. I hope you can see it. So this is a much more effortless suturing than the one that I showed in the previous video with the straight laparoscopic instruments. And the gory part is coming up. Usually the way prostatectomy used to be done is with two surgeons, well, an assistant and a surgeon making a cut in the abdomen, and then kind of trying to look inside the pelvis, trying to remove this prostate that usually has a tumor in it, and trying to avoid all the nerves and blood vessels right around it, because people want to preserve as much function down there as possible. And of course you can't see the gory part, but the robot is very good at removing this abnormal piece of tissue. Da Vinci was invented in 1999 in the United States. You can see how many centers use it now. It's huge. The United States is, we all know about their healthcare system. It's privatized. There's a lot of funding that comes in from the private sector. So there's a lot of opportunity for innovation, much more so than in Canada. So even though Canada's population is about 10 times or 10 times smaller than the size of the US, we do have many fewer centers that have adopted the robot. Toronto General Hospital is one of the biggest, most advanced surgical centers, in my opinion, in the country, and this is how many cases we have done, surgeons over there have done. It's over 1,000 cases since 2008, when the robot was first used. So the urologists and the gynecologists did about 800 cases, and then the colon and rectal surgeons and chest surgeons started a little bit later, and the reason for it is technical. It's more just the prostate surgeons and those types of surgeries benefit much more from the robot, and the other ones can actually be much more longer and bulkier and frustrating, because the other bowels and whatnot are much more mobile, and they require the robot to be repositioned a lot, so the duration of the surgery can be doubled, which is not very efficient. It's not good for the patient to be under it for a long time. And this is the robot that I'm going to show here is actually much more autonomous than the Da Vinci robot. This robot is used in Toronto General Hospital. There was an article in the Globe and Mail. This is our OR number 20. And this is an imaging robot. It gets an input from the CT scanner of a patient's brain and is able to position itself during the surgery in a way that the surgeon can then see a very small tumor in the base of the skull and remove it. And I think it's really important to differentiate between the autonomous and non-autonomous robots. There's a whole slew of literature out there, but Da Vinci robot is really an extension of the surgeon's hands. It doesn't think, it just does whatever it's told to do. And this robot is a little bit more autonomous because it has to think based on the information that was put into it. And HAL was not a robot, it was a computer, but it was fully autonomous to control a ship. So if a mistake is made by HAL, it can have much bigger consequences than a mistake by a less autonomous robot, because they'll make decisions. And I talked about this a little bit. Why do we not use robots for all surgeries? Because it's just, you need the right patient and you need the right organ to do it on to make it efficient. And also it's not cost effective. Does the incremental difference in the slightly less tissue damage, is it really worth the cost? The Da Vinci surgical system, one robot is worth $2.5 million US, the typo. And then per case, there's an extra cost. So draping the robot in every case is extra $300, and each one of the robotic instruments has a per case cost. So if you look at the studies that were done that compare laparoscopic, robotic, and then open laparotomy surgery, you can see that the robot is really expensive. So it's 10 times, the disposable instruments cost 10 times that of laparotomy, or regular open surgery, and 3 times, or double that of the laparoscopic surgery. This is something we have to keep in mind, especially in Canada where resources are limited. We are a public administered healthcare system. So what all of this makes me think of, especially the book that I'm reading on ethics and robotics, is how can we do harm? And harm has been done in other areas of robotics, in military robotics, in carrying or designing robots for elder care, for example. Even robots that, or even cars that are now independently driving themselves and parking themselves can make a decision to run over a child versus a chicken. If they see it. I mean, there's a lot of things that can go wrong if you don't think about it ahead of time. And this is just a really interesting concept that I read in a paper by an engineering computer science group from Greece that reviewed all the robotic innovation in surgery right now. And they reviewed some of the newer projects that are happening right now that do involve independent robots. They're very experimental. And how they define the independence and autonomy of a robot is based on the environmental difficulty and how well they can adapt to the environment. So sometimes the environment is really easy. I mean, all you have to do is tie a knot and there's nothing around you. But if there's a huge abdomen with a lot of blood in it, the robot has to measure that many more variables to make a decision. There's also mission complexity. What's the robot have to? What is it going to have to do? Is it going to have to tie a knot, or is it going to have to find something and then make a decision and then repair, etc., etc.? And then also, how much of human input do we have? Is the robot going to be limited in what it's doing by somebody who's watching it, or is it going to be completely independent? So this is the paper that reviewed all of these advancements, and they did talk about some things that are happening right now. So in 2010, this is a Berkeley robot that was taught to independently tie a knot. It tied a surgical knot using only the cameras, only the sensors by the robot with no human input. That's very early. I mean, tying a knot is something that you learn in first year of medical school, if not even as a surgeon. Or, I mean, we know how to tie our shoelaces when we're kids, but for a robot, that's a huge advancement. This is a robot that aspirated a cyst in a turkey breast using ultrasound. So instead of having eyes, it used ultrasound to see where the cyst was and to target a needle to aspirate it. And this is an actual cadaveric inner ear. And in this experiment, they programmed the robot to perform a cochlear implant. And it was actually able to measure the depth and the toughness of the tissue. So you can just, I mean, the complexity of what these robots have to understand and decisions they have to make is huge, but the progress is being made. And this is a robot that is actually being used today. It's called Cyborg system, and it is a robot that performs radiation injections to burn a patient's tumor based on an X-ray input. So it can identify the tumor, and it can then send one or several X-rays to burn the tumor. And another speaker alluded to this earlier. Nanotechnology is being developed as well, and this is a contrast that's injected that sticks around only to the tumor, so that we can more precisely remove it. And some of the even more exciting things that will be happening are micro or nano robots that will be able to go into someone's bloodstream, kind of like the movie Inner Space. How many people have seen her face here. Where a little robot can go into someone's bloodstream or into someone's blood vessel and kill plaque or unplug a blood vessel that's causing somebody to have a heart attack. So that's a whole different bag of worms that I'm not going to go into, but it's being investigated right now. This is a rounding robot. You kind of have to wonder why the surgeon hasn't gotten off his desk and come to personally see the patient. Instead, he chose to sit in front of a screen and communicate with her and ask her about her wound healing and her pain via an iRobot. But this is being used, and it is important, I think, if the patients are far away, they've had their surgery, now they're back in Thunder Bay, Northern Ontario, and they have a question about their wound. So I think there's uses for these robots, definitely, but I find these things very funny. And they do get stuck all the time in the hallways, so you inevitably have to have somebody unstick them, and so they can go back to their station. This is an artistic photo by a Dutch photographer, but this is actually also happening. These are called elder care robots, and they're developed to help the elderly, to remind them to take pills, or to tell them if there's a fire, or to dial an ambulance if there's a fire. I really like this photo because I think it really, in my mind, brings up a lot of thoughts about, well, what if that lady really likes the robot, and when the robot breaks down, she gets really, really sad. And maybe the pet really doesn't like the robot because he's jealous. But I mean, us as humans, we're very emotional beings, and there have been reports of soldiers in Iraq who have become very emotionally attached to the robots that go in and investigate and disarm the mines, and then are later on killed. And they've actually cried about this, and it's been reported. So we don't really know how we're going to react to these things, even on an emotional level. And I think it's worthwhile being prepared for it, at least talking about it. This is the book. It's a fascinating book. Came out in 2012, edited by a couple of researchers from MIT, and it's incredible. Actually, it's opened my eyes to what is happening out there. Not only on a mechanistic level with robotics, but on a very spiritual, intellectual level, where there's a whole chapter about programming a spiritual robot, and there are actually people out there who are creating a Buddhist robot. And to me, this just illustrates the point that us as human beings, we are so interested in deconstructing who we are as human beings and I think through robots, we want to learn more about ourselves so we can build that robot again. It's kind of like breaking down a car, a toy car, as a curious kid, so you can build it up again so you can understand it much better. Isaac Asimov published these laws of robotics in the 1950s. Number 1 was to protect humans. Number 2, robots need to obey orders. And number 3, they need to preserve themselves. These laws don't really apply to what's going on today. They are conflicting. What about if a military robot is trying to protect a soldier and sees an enemy? I mean, it can't always protect all humans. And it just shows us that there's a lot of gray zones in robotics. This is an example of a military bomb diffusing robot. It has many sensors and cameras, and it can find a bomb and defuse it. This is an example of a fascinating new machine that was shown in Tokyo in 2012 in an exhibit. It has a lot of features that I can't understand, but I do know that it's very powerful. It can be manipulated or run remotely, or by a person who sits inside the machine. It's on 4 wheels. It can throw things. It can throw weapons. I'm sure it can shoot and kill people as well. It's kind of very futuristic, but it's happening now. You can buy it for $1.3 million US dollars. This was a really good quote by Patrick Lynn. He is a doctor of philosophy in California Polytechnic State University. He gave a briefing to the CA officials regarding robots in the military, and I really like it. He said that integrating ethics may be more cautious and less agile than a do first, think later approach. but it helps us win the moral high ground, perhaps the most strategic of battlefields. Engineering and Physical Sciences Research Council of the UK posted this on their website in 2010. These are the guidelines for engineers and people who are creating robots and who are thinking ahead into the future and want to do it in a way that is the most safe. So a few things that they say is that robots should not be designed solely or primarily to kill or harm humans, but they acknowledge, except in the interest of national security. Humans, not robots, are responsible agents. Robots are products, and they should be designed using processes which assure their safety and security. Robots are manufactured artifacts. They should not be designed in a deceptive way to exploit vulnerable users. And the person with legal responsibility for a robot should be attributed. I think this is really important. I think anytime there's a robot or robotic device that is autonomous, it's going to make decisions and potentially damage something or someone, there should be somebody who's attributed to be responsible for any consequences. But I'm not aware of any laws that are out there regarding this. And this is another article and interview from The Economist. It was published in 2011, I believe, and they were exploring all of these issues. And one of the editors was interviewed, and his concern is that if this is not thought about currently, and there's a major disastrous consequence of a robot killing someone or doing something, it can actually have devastating consequences for robotics in general. And he talked about having more clarity in laws and what robots are meant to or allowed to do, on having transparency in the processes that happen within a robot. So for example, according to Nevada law, the driverless car has to have a black box, so it records all of its decisions in case there's anything that needs to be later learned from or investigated. And the machines need to embody the right ethical rules. This is still a point of a lot of debate and controversy, because it is culturally, there's a lot of cultural disputes, ethical principles, and also what ethical principle or approach are we going to use? Are we going to be utilitarian? Are we going to be Kantian? And I don't even want to go there because I'm not an ethicist, but it's interesting. And so do I think we're ready for robotics and for independent robots in surgery? I don't think so at all. And I think the result of that is the fact that doctors are very busy taking care of patients. And really what we want for our patients is for them to get the best treatment in the quickest, least painful way, and prolong their life and quality of life. But we do have to think about it, and I think it's good to be here and talk about it. This is a quote from The Economist again that I really, really liked, and it says that technology has driven mankind's progress, but each new advance has posed troubling new questions. Autonomous machines are no different. The sooner the questions of moral agency they raise are answered, the easier it will be for mankind to enjoy the benefits that they will undoubtedly bring. So, that would be all. Thank you.